Today's topic is nerve injuries. As you all know, neuron is a structural unit of nervous system and it has an ability to transmit impulses between central nervous system and peripheral part. We have two basic types of neurons, that is a sensory and motor. This is the picture of a motor neuron which has a ability to conduct impulses from central nervous system to periphery. And this is a sensory neuron which has an ability to conduct impulses from periphery to central nervous system. Axon, as you all know, it is a single process extending from the cell body and it varies in length and diameter. Axon conducts impulses away from the body and dendrites carries impulses towards the body. Okay. This is the dendrite and this is the axon. And coming to the topic, nerve injury. Nerve injury is nothing, it is a breakdown of nerves. By definition, nerve injury means partial or complete interruption of normal physiology of the nerve. That means the basic nerve conduction will be affected. And when we classify the mechanical type of nerve injury, we have basically three types. Anesthesia, that is a complete lack of stimulus detection and perception. Next is paresthesia, altered sensation. That means stimulus detection may be normal or abnormal. Stimulus perception is unpleasant but not painful. Dysesthesia is an altered sensation consisting of abnormal stimulus detection and perception. Stimulus may actually perceived as painful. In paresthesia, you have an unpleasant perception, where in dysesthesia, the perception may be painful. And the reason for a nerve injury can be a focal contusion like gunshot wounds. It can be a stretch or traction injury. It can be a drug injection injury. It can be due to compression. It can be due to crush injuries, avulsion, laceration, electrical burns, idiopathic, and other causes like viral infection, metabolic, and neural disorders. And a patient with nerve injury may present pain, loss of sensation, loss of motion, loss of power, loss of reflexes, wasting, trophic change, contractures, or a combination of one or two, or all. Then the classification of nerve injury, it is very important, and we have two important classification, that is Seddon's classification and Sunderland's classification. And before moving to the classification, you should know the layers of nerves. As you all know, inside there is an axon, and outer to axon there is an entoneurium. Outer to entoneurium you have perineurium, and outer to perineurium you have epineurium. That is inner to outer, axon, entoneurium, perineurium, and epineurium. So first is Seddon's classification. Seddon has classified nerve injuries into three, that is neuropraxia, axonatomosis, and neurotomosis. Neuropraxia, there will be just stretching of nerve. Axonatomosis, there is a cut through the axon. Neurotomosis means a complete transection. This is a Seddon's classification. Sunderland's classification is a slight modification of Seddon's classification. This is Sunderland's classification. As per Sunderland, the grade 1 is same as the neuropraxia as described by Seddon, and grade 2, which is known as axonatomosis, it is same as the axonatomosis described by Seddon, and the grade 3, grade 4, grade 5 is the subclass of the neurotomosis described by Seddon. Okay, so in grade 1 neuropraxia, there will be a stretching. When grade 2, you have to think from inner layer to outer layer. Okay, so when in grade 2, the axon will be injured. No other neural layers will be injured. In grade 3, that means axon and the next outer layer to axon, that is axon and entoneurium will be injured. In grade 4, axon, entoneurium, and the next to entoneurium, that is a perineurium, that is injured. In grade 5, axon, entoneurium, Perineurium and epineurium will be involved. That means there will be a complete transection of the nerve. So this is Sunderland's classification. We can see the details. The first degree injury, that is a neuropraxia. Sunderland's first degree injury is same as Seddon's neuropraxia. This is the most common type of injury. It is caused by applying pressure over a nerve for a short period, leading to occlusion of the blood vessel and hypoxia. Axon is not destroyed, but demyelination occurs. There is no cut. There is only a stretching. Axon loses the function temporarily for a short time, which is called conduction block. The function returns within few hours to few weeks. First degree of injury is called sudden neuropraxia. Then Sunderland's second degree injury, that is axonatomosis. It is due to prolonged severe pressure which causes Wallerian degeneration. The endoneurium will be intact. That means the cut will go through axon only. Outer to axon, that is the endoneurium will be intact. Repair and restoration of function take about 18 months. Second degree of injury of Sunderland is called axonatomosis as described by Seddon. The third degree injury, in the third degree injury, the endoneurium is interrupted. That means in the second degree, there is axon is interrupted. That is the axonatomosis. In third degree, axon and endoneurium is interrupted, and outer to endoneurium, that is the epineurium and perineurium, will be intact. After degeneration, the recovery is slow and poor or incomplete. Third, fourth, and fifth degrees of injury are called neurotomosis. Fourth, this type of injury is more severe. Here, perineurium is interrupted. In the previous third degree, you know that axon, endoneurium is affected, perineurium will be intact. But here in fourth degree, axon, endoneurium, and perineurium will be affected. Fasciculi of nerve fibers are disrupted and disorganized. Regeneration is poor or incomplete. Fifth degree, that means a complete transection. That means your axon, endoneurium, perineurium, and epineurium will be involved, and there is a complete transection of the nerve. Useful regeneration is not possible unless the cut ends are rearranged and approximated quickly by surgery. And this is about the Seddon's and Sunderland classification. There is another addition by Dellon and McKinnon to Sunderland's classification. He told that there is another degree, that's a sixth degree, that is a combination of all. It is believed that within the same nerve trunk, all nerve fiber do not exhibit same degrees of nerve injury, while others may not be injured at all. Degeneration in the neuron. When a peripheral nerve fiber is injured, the degenerative changes occur in the nerve cell body and nerve fiber of same neuron and adjoining neuron. The degeneration towards the cell is called retrograde degeneration, and the one way from the cell. And that means that the site of injury is called Wallerian or orthograde degeneration. Wallerian degeneration is the pathological change that occurs in the distal end of the nerve fiber, that is the axon side. It is named after the discoverer Waller. It is also called orthograde degeneration. Wallerian degeneration starts within 24 hours of injury. Change occurs throughout the length of distal part of nerve fiber simultaneously. Diagnosis. We can get a diagnosis through a proper history and through a clinical examination. In clinical examination, we have clinical neurosensory testing like mechanoreceptive test and nociceptive test. Mechanoreceptive tests are 2-point discrimination and brush directional stroke. Nociceptive test can be pinprick or thermal discrimination. The timing of repair, primary repair 0 to 2 days, delayed primary 2 to 7 days, secondary after 7 days. Management, we have medical and surgical management. Medical management, the primary drug is steroids. Prednisolone is a steroid in a dose of 1 milligram per kilogram per day for 10 days in divided doses to start with, which is gradually tapered and withdrawn over a period of 2 to 3 weeks. nerve paralysis due to peripheral inflammatory lesion respond well to this treatment. If the paralysis is secondary to a viral infection like herpes zoster, we need an antiviral drug in addition to the steroids. But the central lesion will not respond to medical management alone. Physiotherapy in sometimes in the form of transcutaneous electrical nerve stimulation, that is TENS, with galvanic current stimulation is given, which produces satisfactory results. Surgical management can be decompression, anastomosis, cross innovation, and nerve graft. Decompression, it is used if nerve compression occurs resulting in neuropraxia. For example, in case of trigeminal neuralgia, the trigeminal nerve may be compressed most commonly by the superior cerebellar artery. In that cases, we can avoid the compression. That means we can decompress the compression of the superior cerebellar artery on the trigeminal nerve by placing an intermediate material between the vessel and the nerve, like fasciolata or Teflon. Then anastomosis, if there is a cut and there will not be a more than 1 centimeter gap, you can do microsurgical repair of the cut ends. It is useful when there is no loss of nerve tissue. If there is a gap of more than 1 centimeter, we have an option of nerve graft. We have to replace this gap with some other nerves, and the most commonly used nerve for nerve grafting are the sural nerve, and when considering the facial nerve, another option is greater auricular nerve. When talking about greater auricular nerve, it can be used as a nerve graft for facial nerve due to its close proximity, and the diameter of the nerve matches that of facial nerve, and up to 10 centimeter of nerve can be harvested. Disadvantage is it may affect its supply. That means it may cause ear numbness. And one of the most commonly used nerve for nerve grafting is a sural nerve graft because of its greater length up to 4 centimeter. And definitely it also has a disadvantage of foot numbness. Nerve transfer. Another option is nerve transfer. And when talking about or when considering the facial nerve, the most commonly used nerve for nerve transfer is hypoglossal nerve. And in this case, we can release the cut end of the facial nerve from the stylomastoid foramen, and we can suture it with the hypoglossal nerve. For that, we have to do a hemitransection of the hypoglossal, and we can suture it with the hypoglossal nerve. That is a nerve transfer. Then another option is cross nerve grafting. Cross nerve grafting is in one side of the nerve is affected, we can cross innervate it with the opposite side. In case of facial nerve, if one side is affected, you can cross innervate it with the corresponding part of the opposite side. These are the options of the surgical management. This is about the nerve injuries. Thank you.